How are you? Good evening. Today we are going to discuss about staphylococcal infections. These are gram-positive cocci. Okay, let's discuss what are the gram-positive cocci. Gram-positive cocci are viridans, lactococci, and enterococci, staphylococci, streptococci. So today we are going to discuss about staphylococcal infections. So these are divided into two families. One is micrococcaceae and another one is streptococcaceae. These two can be differentiated by catalase test, and micrococcaceae members are positive for the catalase test and streptococcaceae members are negative for catalase test. Okay, so these are gram positive micrococcaceae which are arranged in the tetrads or clusters, whereas streptococcaceae they are arranged in the chains or pairs. And micrococcaceae they are their genus, according to their genus, Micrococcus, Staphylococcus. Micrococcus they are arranged in the tetrads and Staphylococcus they are arranged in the clusters which are coagulase positive. So coagulase negative members are other species like Staphylococcus saprophyticus, Staphylococcus lagdunensis, Staphylococcus lyphaeri, Staphylococcus hemolyticus and Staphylococcus warnerifi. So most common infections will be seen with Staphylococcus saprophyticus. Okay, coming to Staphylococcus aureus. These are spherical cocci about 1 micrometers in diameter. They are arranged in the clusters. Okay, Staphylo means some grape-like, and they are usually seen as clusters. Okay, and during according to the plane of division also, these are arranged in that cluster type. Okay, so these are catalase positive as we discussed, coagulase positive. Okay, Staphylococcus aureus is only coagulase positive, remaining are coagulase negative. So this can be demonstrated by tube coagulation test. Okay, and these are facultative anaerobes. Facultative anaerobes means we know they are aerobes actually, but they can live within the anaerobic environment also. Okay, and these are non-motile, non-spore forming, and sometimes there will be capsule around, microcapsule. Okay, some golden yellow pigmentation on the nutrient agar. Okay, and beta hemolysis will be seen on the blood agar, and localized pyogenic infections, life-threatening systemic infections in man will be seen. So coming to virulence factors, what are the virulence factors? Virulence factors are cell wall associated factors. So these cell wall associated factors will be thick peptidoglycan layer and teichoic acid. Additional factors of the cell wall are proteinuria and clumping factors. Coming to peptidoglycan, it is similar to the gram-positive bacteria, but it is somewhat thicker. Okay. So next, it induces the inflammatory response and also has endotoxin like activity. Okay, normally endotoxins are produced by gram negative, but these peptidoglycan which also has a endotoxin like activity. Okay, teichoic acid which is made up of ribitol phosphate polymerase. So these ribitol phosphate polymerase, they go and bind with the mucosal membranes, mucosal surface. So these they will inhibit the opsonization. Okay, so recognition won't be that easy due to the presence of teichoic acid and inhibition of opsonization. Okay, cell surface adhesions are clumping factor or bound coagulase which give positive coagulation test, and this is most important virulence factor which is bound coagulase or clumping factor, and fibronectin binding adhesions, collagen binding adhesions. These are helpful in addition of the cell to the surfaces. Okay, and host cell surfaces. Okay, protein A which is SPA, this has biological properties like anti-complementary. So complement system can't break this due to the presence of this protein A, and chemotactic mitogenic inhibition of opsonization. As we saw, it is also present with teichoic acid, and induction of the platelet damage will occur. So what will happen due to this protein A? This protein A go and binds with the Fc portion of the IgG antibody. So remaining FAB portion of the antibody is remains vacant. So this FAB will bind to other antigens which are present in the same clinical samples. So this is known as coagglutinin reaction mediator. Okay, that protein A, which is coagulation reaction mediator. So and microcapsule will be present, and which is made up of polysaccharide. This microcapsule, which is zwitterionic. As we know, zwitterionic means it has both cationic and anionic forms. Okay, so due to the presence of this zwitterion, abscess formations will occur. So coming to the other virulence factor, which is toxins. Toxins are hemolysins. They are alpha toxins, beta toxins, gamma toxins, and delta toxins. These toxins, they will cause lysis of the RBC by rupturing the membrane of the RBC. Okay, they exhibit various these hemolysins. They also exhibit various actions such as dermonecrotic, cytotoxic, neurotoxic, and leukocidal activities. So leukocidins or Panton-Valentin toxin. This acts synergistically with the gamma hemolysin, so to damage the leukocytes, RBCs, and macrophages. So synergohemonotrophic toxins. These are gamma hemolysin along with the PV toxin. Okay, which is Panton-Valentin toxin. So these are individually, these are inactive. When they combine only, they will become active, and they will cause leukocidal activity. Okay. So PV toxin, which is a methicillin resistant Staphylococcus aureus, which is associated with the community acquired infections. Okay, clear? So coming to next virulence factor, which is epidermolytic or exfoliative toxin. It has a further divided into two subtypes. One is epidermolytic toxin A, epidermolytic toxin B, which is responsible for Staphylococcus scalded skin syndrome. Okay, and blisters will be seen, and these blisters will further leads to bullae formation, and further leads to, in severe cases, if we won't treat this condition, it further leads to exfoliation, separation of the epidermal layer, outer epidermal layer, leaving the underlying skin. You know, skin has epidermis, dermis, and hypodermis. Outer epidermis layer will become exfoliated, means it get peeled off, and you will see that the peeling of the membranes on the skin, we can clearly see, and remaining skin will be normally left. Okay, this is known as Nikolsky sign. What we call this as Nikolsky sign. It is most commonly seen in the children. Okay, and adults even we will see. And Ritter syndrome will have fever, lethargy, irritability with poor feeding, which is commonly associated with the children. Okay, and neonates, infants, we will see this. And milder forms will be pemphigus neonatarum. Again, this is skin infection, pemphigus. So we have many forms of pemphigus: pemphigus vulgaris, pemphigus foliaceus. This is pemphigus neonatarum, as this is seen in the newborns, and bullous impetigo will be also seen in milder forms of the infection. Okay, coming to enterotoxin, this is a preformed toxin. Okay, so incubation period, which is short. Preformed toxin means it is already we took it before only, along with the food. Okay, it is secreted outside only, and we are taking it directly, we are inhaling, or we are taking it along with the food, and we are getting the infection. Okay, serotypes will be 15 serotypes. They are A to E or G to P. This is the serotype A, which is responsible for food poisoning, and all means due to the food poisoning, this serotype A will enter. Okay, all acts as super antigens. Okay. So serotype F, which does not cause food poisoning, but it causes the toxic shock syndrome. Let's go into toxic shock syndrome toxin, which is very, very important, as it may ask for 5 marks. Okay, 5 marks or 3 marks. Okay, as they wish. So this toxic shock syndrome toxins, they are of two types. One is TSST1 and TSST2. These acts as super antigens. So TSST1, which is a Staphylococcus enterotoxins. Okay, we will discuss what is super antigen. Okay, Enterotoxin F, which is also known as pyrogenic exotoxin C, which is common type of the TSST1. Okay. Enterotoxin B or C, which is may also be commonly associated with the toxic shock syndrome. Okay. Risk factors will be post surgeries. Most common risk factor is using vaginal tampons in the menstruation. Okay. Traumatic or burn wound infections, and non-menstruation women or men also will get affected because of the staphylococci abscesses formation and osteomyelitis. Okay, these all will be the risk factors of getting the toxic shock syndrome. Okay, so as we saw before, this is a super antigen. So now let's go into pathogenesis. So through vaginal tampons, these staphylococcal uh, toxic shock syndrome toxins, they will enter into the bloodstream, and they will they access super antigens. So they access super antigens. Super antigens means they don't need the antigen presenting cells. They just what they will do, they will bypass the antigen presenting cells, and they directly go and bind to the non-specific V beta region of the T cell receptors, which are non-specific. Okay, here we see this is APC. Okay, these are super antigens. They are just bypassing the APC, and they are directly binding the V beta region of the T cell receptors, which are non-specific. Okay, this this V beta region is non-specific. So this Th2 cell. So this leads to massive non-specific cytokine release. It may lead to cytokine storm. Okay, and involvement of multi-system fatal diseases. Sometimes polyclonal B cell activation and hypergammaglobulinemias will also be seen. Okay. Okay, that's fine. Now about toxic shock syndrome. So coming to clinical features. Clinical features will be fever, hypotension, mucosal, hyperemia, vomiting, diarrhea, confusion, myalgia means muscle pain, abdominal pain. Hyperemia occurs. Okay, hyperemia associated with some infections or allergies. Hyperemia will be seen, and fever, these all will be seen. Pain and erythematous rashes will be seen. Rapid involvement of organs like liver, kidneys, lungs, gastrointestinal tract or CNS. So coming to laboratory criteria, negative blood culture for other pathogens and lack of evidence of other cause of infections. So blood culture is positive for only the Staphylococcus aureus. Negative blood culture will be shown for other pathogens. Okay, anti-TSST antibodies which appear in the convalescent stage. If they do not appear, the infection will become so severe. Okay, diagnosis will be detection of the TSST can be done by LAT and enzyme immunoassay. Okay, latest agglutination test and enzyme immunoassay. PCR-SS which will be done for both type 1 and type 2. Other findings will be altered liver function test and kidney function test with low platelet counts. Treatment will be, as there is a capillary leak, aggressive fluid replacement should be done, and adrenergic drugs which are vasopressors should be given to reverse the hypotension. So examine for and remove any colonized foreign particles like foreign bodies like vaginal tampons. If they are there, we should remove them. And clindamycin, which is a preferred drug for toxic shock syndrome, it should be given along with the anti-staphylococcal penicillin, okay, which is a cloxacillin for methicillin sensitive Staphylococcus aureus, or vancomycin for methicillin resistant Staphylococcus aureus. For clindamycin resistant cases, we should give linezolid. Okay, linezolid can be used for toxin suppression. Addition of vancomycin, which is not required for this case. Okay, only linezolid should be given. Okay, along with the vancomycin. Vancomycin, which is not generally required. Okay. So coming to extracellular enzymes, it secretes the coagulase enzyme. It comes in contact with the blood, which leads to clotting or coagulation of the blood by activating the prothrombin. With prothrombin will act on fibrinogen. It converts fibrinogen into fibrin. This fibrin means insoluble insoluble fibers it will form, and it strengthens the clot. Okay, so this is our bacteria, uh, which is gram positive cocci. So around this we are seeing this fibrin clot. So due to this presence of fibrin clot, this bacteria can't move, right? It is localized, so it can't move through the blood stream, and this macrophage also can't lyse this bacteria due to the presence of fibrin clot. So no phagocytosis. So due to the presence of fibrin clot, it is escaping from the phagocytosis. So it serves as a base of tube coagulation test. Okay, as there is a clot, if you do coagulation test, so it will be positive. Most important test which is used for the identification of Staphylococcus aureus. Normally the tube coagulation test, if we do, if there is no Staphylococcus aureus, it will be like in milk color like that. If there is there due to clot formation, and if you invert it, the flow won't be there. Okay, after inversion. So other enzymes will be heat stable thermonucleases and DNase, which is specific for the Staphylococcus aureus. So only Staphylococcus aureus contains these enzymes. Remaining species won't contain these. Okay, Staphylococcus aureus only contains this. Okay, staphylokinase, which breaks the fibrin clots, which facilitate the spread of infection. Hyaluronidase, which breaks the connective tissue networks. Lipases and phospholipases, they break down the lipids, as we saw this. Lipases, lipids, they will break. Okay, so that's it for today, and we'll continue with pathogenesis in further classes. Okay, thank you guys for listening to me patiently. Thank you.